So it looks like we have almost 50 people. So we'll go ahead and start as more people start to trickle in. Once again, my name is Casey Cable. I'll be moderating this chest chat today, this webinar on monoclonal antibodies for COVID-19, who, when, and how. So I want to introduce our expert panels today. We have three, and we thank you for giving their time. We have Masa, Jennifer, and PJ. So I'm going to have each one of them introduce themselves first, and then we'll do go into a quick presentations from each one of them, and then we'll get into our discussion.
Thank you. Hi, I'm Masa Bhatti. I am an infectious disease physician, assistant professor at the University of Minnesota. I have been, over the last 8+ months, have been working with some of the monoclonal antibody studies in the inpatient side. But my presentation today will mostly be covering the use of monoclonal antibodies in the outpatient setting. Thank you.
Good afternoon. My name is Jennifer Tudor. I serve as the Deputy Chief Medical Officer in the County of San Diego, and I've also served as the lead for the healthcare outreach and education sector during this pandemic. So what I'll be presenting today is how we've come together as a community to build and offer monoclonal antibody regional centers, or as we call them, MARCs. Thank you.
And I'm PJ Miller. I'm fellowship trained in both hematology and critical care medicine, and assistant professor and the medical director of the medical oncology ICU at HRM Health Wake Forest Baptist in Winston-Salem, North Carolina. And I'll be discussing our experience with using monoclonal antibodies in an inpatient ICU setting.
Well, thank you to all three of our panelists for being here, and we appreciate the time that they're taking out of their busy day. So let's jump right in. Once again, if anyone has any questions or would like to direct those to the chat in the Q and answer section, we'll try to get to those as much as possible and trying to keep them onto topic today. So up first, we'll have Masa give her presentation.
I'm going to just kind of be talking about the outpatient treatment with monoclonal antibodies. And I do want to give a little bit of a caveat as I prepared this presentation about a week ago, that the information that I will be sharing is primarily covering the monoclonal antibodies that do have FDA emergency use authorization for use in the outpatient setting. And that may change as the spread of the Omicron variant picks up throughout the US. And I'll go into that in one of the slides towards the end of this presentation. So just a little bit of the background. Monoclonal antibodies that are really neutralizing monoclonal antibodies are recombinant proteins that are derived from B cells of either convalescent patients or humanized mice. And we know that the primary antigenic epitope in the SARS-CoV-2 is the S protein. And it's the S protein that facilitates the binding of the virus to the ACE2 receptor, which then causes entry into different cells that express the ACE2 receptor, primarily respiratory, the gastrointestinal endothelium. So the main function of the monoclonal antibodies is to then bind to the S protein at different sites of the receptor binding domain of the S protein and neutralize the ability of the virus to fuse with the target cell. The monoclonal antibodies usually will either bind to one or two, depending on if there is a combination of non-overlapping sites on the receptor binding domain. And the attractiveness in the development of these different types of monoclonal antibodies to use in the clinical setting as compared to using convalescent plasma from recovered patients who have had COVID or have been vaccinated is that these monoclonal antibodies can be mass produced. They don't have the same risks that getting convalescent plasma from people do with bloodborne disease and so forth. And you have the ability to deliver very high titer neutralizing antibodies. And that gets away from using low titer convalescent plasma. But in the same light, some of the setbacks of these monoclonal antibodies is the potential for the evolution or the mutational changes on the receptor binding domain that then reduces the ability for these monoclonal antibodies to neutralize the virus. And we know that production of anti-spike or anti-receptor binding domain IgG antibodies is generally associated with being able to neutralize the virus and protect from developing SARS-CoV-2 infection. And we also know that those who are able to produce neutralization antibodies early before day 14 of symptoms generally end up doing better. So that early neutralization activity, it correlates with improved clinical signs and lower mortality as compared to those who have who developed late neutralizing antibodies. So you can see that here. And we also, and in the same light, you can see that those who do have development of early neutralizing antibodies also have lower peak viral loads as well. That then kind of leads to the reason why antibody therapy kind of acts as an antiviral, and why we see its most effectiveness when used early and during mild illness, rather than later on during this kind of severe illness or critical illness where much of the disease pathology is driven by inflammation. So these are kind of three of the big randomized clinical control trials that have been published to date. And kind of the basis of some of the FDA's EUA for these three monoclonal antibodies to be used for the treatment of mild to moderate COVID-19. So you can see that BLAZE-1 was the use of bamlanivimab and etesevimab. REGEN-COV used a combination of kesarivimab and imidivimab, and COMET-ICE used sotrovimab in early all ambulatory adolescents and adults with early diagnosis of COVID-19 or positive PCR or antigen, symptoms no more than 7 days. And you could see kind of just the results down the line that there was significant relative reduction in hospitalization or death with all three of the studies with varying absolute risk reduction. And so based on these results, the FDA went ahead and gave EUA approval to use of these monoclonal antibodies for treatment of non-hospitalized patients who had mild to moderate COVID-19 and were at high risk of clinical progression. Now, bamlanivimab and etesevimab, after it was first approved to be used on an emergency use basis, had their EUA revoked for a short amount of time when the Gamma and Beta variant were kind of circling throughout the US, because this was one of the first combination monoclonal antibodies that were shown to have a little less efficacy towards those two variants. And when the Delta surge kind of came and outcompeted those two variants, then the EUA was given back so that these two agents could be used again. And this will again become relevant as the Omicron variant is kind of spreading to the US and seeing how it evades neutralization by many of these monoclonal antibodies. So currently these three are the bamlanivimab, etesevimab, and this is the REGEN-COV-2, kesarivimab, imidivimab, and sotrovimab are currently have EUA to be used for persons who are at high risk of progression to disease before 10 days of symptom onset. And so some of the limitations to the use is, again, you can't be hospitalized for COVID-19 unless there is one disclaimer that if you were incidentally found to be positive for COVID-19 inpatient and are at high risk for progression, that you that you could then get the monoclonal antibodies, but other limitations to use is requiring oxygen therapy or an increase from your baseline oxygen therapy. So then we move on to prevention of COVID-19. And so this is using monoclonal antibodies as post-exposure prophylaxis. This is a study that was published in the New England Journal of Medicine, subcutaneous Regen-COVID antibody combination to prevent COVID-19. And here participants, both adolescents over the age of 12 and adults, who were exposed to an index case were randomized within 96 hours of that contact with their household member to either placebo or subcutaneous Regen-COVID-2. And the primary efficacy endpoint here was the development of symptomatic PCR confirmed SARS-CoV-2 within 28 days. And here they saw that if they were able to give persons who had close contact with someone who was positive and were able to receive the monoclonal antibody within 96 hours of the contact, that there was a significant 81.4% relative reduction in development of symptomatic SARS-CoV-2 infection. Now, this was also seen, as you can see in the graph up at the top, that within the first week, they saw a relative reduction of about 71.9% in the development of symptomatic SARS-CoV-2 infection. And it got even higher when you were only looking at within weeks 2 to 4, that relative risk reduction was 92 to 96%. Looking at the second figure here, they were also able to see that those who did become infected and had either asymptomatic or symptomatic SARS-CoV-2, that Regen-COVID prevented much higher viral loads in both asymptomatic and symptomatic persons. A follow-up to this study that was not in the paper, but it was a press release, is that when they looked at the efficacy of Regen-COVID beyond the 28-day pre-specified follow-up period, that between months 2 to 8, that they were able to maintain an 81.6% relative reduction, again, in symptomatic SARS-CoV-2 infection. So not only did that protection last within the 28 days, but that it appeared as if that protection went all the way up to the 8-month follow-up period. And during that 8-month follow-up period, that they saw the 0 hospitalizations for COVID-19 in the Regen-COVID group and 6 in the placebo group, and suggesting that there was the potential that providing this combination monoclonal antibody therapy provided a very long-lasting immunity for those who were not yet infected as a post-exposure prophylaxis. So that led to then the FDA's EUA for post-exposure prophylaxis, in which only 2 combination antibodies are currently approved for that, and that's the Kesarivimab, Imidivimab, and Amilimumab, Etzivimab, that are currently authorized for those who are at high risk of progression to severe COVID-19, including hospitalization and death. Or death, and are either fully vaccinated or not fully vaccinated, or who are not expected to mount an adequate immune response to their vaccination. So if they're immunocompromised in any way and have been exposed to an individual who has been diagnosed with SARS-CoV-2, or are living in a place that there is a high risk of exposure to someone who has SARS-CoV-2. And this is example of nursing homes or prisons. Now, this is one of the more recent EUAs that have kind of come through, and this is prevention. So this is pre-exposure prophylaxis. And there are two studies currently, the PROVENT trial, which is a ongoing phase 3 randomized double-blinded placebo-controlled trial that's studying the EUA, or that's the AstraZeneca product for pre-exposure prophylaxis in those who are adults greater than 18 years of age. The primary endpoint here was any episode of a first episode of SARS-CoV-2 PCR positive symptomatic illness that occurred from the day of administration to day 183. And you could see that their age range was about 57 years, with about 43% of subjects aged 60 years and older. And you can kind of see the makeup of their participants. About less than 1% had immunosuppressive disease, but 3% were on immunosuppressive medications, and the majority had, a risk factor for bad outcomes with diabetes, obesity, and cardiovascular disease. And what they saw was that there was a 77% reduction in the incidence of symptomatic SARS-CoV-2, and that you could see from the Kaplan-Meier curve, figure 1. There was a second study, Storm Chaser, that's figure 2. This is also an ongoing phase 3 randomized controlled trial, and this of the AstraZeneca product, and this was mostly looking at post-exposure prophylaxis of COVID-19 in adults aged 18 years and over. And their primary endpoint was the development of PCR positive SARS-CoV-2 infection, either symptomatic or asymptomatic. And these patients were enrolled within 8 days of their exposure. Now, they did see a relative reduction of 33% in terms of development of PCR positive SARS-CoV-2 infection. But as you can see here, that was not significant, and that there was no difference in percentage number of cases in the placebo versus the investigational product arm. But that what they did see was after 30 days, there seemed to be protection for those who had not already been infected. So that is why the current FDA EUA for pre-exposure prophylaxis is only for EUA, so texagevimab or clegevimab. And these are for people who are currently not infected and have not had a known or recent exposure. So that's the post-exposure prophylaxis. It's not authorized for that because of the results of the Storm Chaser, and who have moderate or severe immunocompromise, either due to a medical condition or therapy that they're receiving, and who for whom vaccine would they either cannot get a vaccine or are thought not to respond to the vaccine. And again, limitations to the use is this is not approved for treatment of COVID-19. It's not authorized for use as post-exposure prophylaxis, and cannot be a substitute for vaccination as well. So I think this is where things may change depending how the Omicron variant kind of spreads throughout the US and how rapidly it spreads. But you could see here that the Omicron variant has about 15 mutations along the receptor binding domain. And that a lot of these, and you could see the different areas where these monoclonal antibodies bind to. And you can see that on this neutralization assay, that for the Omicron variant, that many of the monoclonal antibodies are unable to neutralize this pseudovirus. And the only one currently that seems to still hold efficacy is sotrovimab. That's the VIR 7831. And the bamlanivimab, etesevimab, and the Regen-COVID and the AstraZeneca all seem to have decreased ability to neutralize the virus. And there is a NIH tracker that, and this is one preprint, but there's a NIH tracker where you could look at the different antibodies and see how effective or how ineffective they are. And again, you could see that sotrovimab seems to hold it seems to be the most effective currently, and less so other monoclonal antibodies. So which monoclonal antibodies may be available for use in the outpatient setting really will depend on how rapidly the variant spreads and which one of these monoclonal antibodies still is able to neutralize the variant.
Well, thank you very much. That was actually, I myself even learned a lot. That was the NIH tracker. That's a really kind of a neat tool that I've yet to be exposed to. So, so thank you for the actually wonderful overview and all of those kind of the great review of so many studies that are quickly coming out because they're kind of hard to keep track of and keep up with. So I think next up is Jennifer, and we'll hear her side of the story. So I'll let her start now.
Okay, so my name is Jen Tudor. As I introduced myself a little bit before, I work in San Diego, and so I serve as the Deputy Chief Medical Officer here and also lead for the COVID outreach and education for our healthcare sector. Part of what we started working on a little more than a year ago as these monoclonal antibodies were starting to come out is to figure out how we could deliver monoclonal antibodies in our area. Our county is about the size of the state of Connecticut as far as the geographical mass. And so we wanted to make sure that we could deliver these monoclonal antibodies in an equitable way. And looking at a stone soup model where we just figured out everything we needed and who our partners were and how to try to mix it all up and make it work. So figuring out the location, supplies, the data we would need, staff, strategy, as well as structure, working with, on the right, our federal partners, our state partners. Of course, we as the county as conveners, because we're not a county that offers medical services. We don't have a county hospital or anything like that, but we contract and work with our partners for that for the most part. And so that would be our local health partners. And that blue circle in the middle is our monoclonal antibody regional center, or now several centers. And we call it fondly the MARC, but really figuring out how we can bring these scarce and valuable resources to people in their own neighborhoods where they live, work, and play, and make sure that everyone has access to what is needed, especially as this is an outpatient medication and it is intended for people at high risk. So the next slide here, you can see that we brought together the 3S model as we were looking for our strategy for this. So we have the stuff, which are our medications from ASPR and from the feds, and supplies such as IV polling, beds, HEPA filters, or HVAC systems, however we needed to figure out what was important to get a site up.
Jennifer, I'm going to be rude and interrupt you. I don't see your slides moving forward.
You don't?
No.
Okay, let's flip over here. Do you see my stone soup now?
We do now.
Okay, it's interesting. I have 3 different versions on 3 screens, but here's my stone soup. You can see this is wonderful. And so thank you for pointing that out, Casey. So the MARC is in the middle here with our partners, state, federal, county, and local health partners. And of course, the MARC represents the patient in the center, right, for that patient-centered care. So going to the next slide, can you see me progress there? Excellent. Okay, so the stuff, staff, and structure that we talked about, and the medications from ASPR, the supplies we have from EMSA and through our public health preparedness and response in our warehouse. And our staff has come from all kinds of different ways. So through the state supply and EMSA, the Emergency Medical Services Authority, our federally qualified health centers and community health centers, as well as our hospital system. So that is where our staff has come from. And then the structure is really interpreted two ways, right? First is the location. You can see the photographs on the right. This is an unused or formerly unused firehouse in Chula Vista. And so this is one of these structures that we use. Space was donated by hospitals, by community clinics and federally qualified health centers, as well as by different cities. And then the other kind of structure are protocols, our policies and procedures. And what we did really allowed us to ramp up and meet capacity as there were surges, and then ramp down as needed as well. So the next slide here shows what our vision was for someone getting service and access to monoclonal antibodies in the county. You take on the left the COVID positive patient who is symptomatic and meets the EUA criteria. And our goal was for them to access the monoclonal antibodies through three different ways, either their primary care provider or physician, the case investigator, so the public health case investigator. Anytime someone had a positive case, the case investigator calls, and this information was there as a resource, or a self-referral, so people could know about it and refer themselves in. We wanted to have no barriers and lots of access to information and awareness. So that green strip shows that we had things available via the web, certainly lots of emails and information, as well as by phone, were all the different ways that we reached out to people to let them know of the monoclonal antibodies. And then on the yellow are all the different locations that we really wanted people to be able to access this outpatient treatment. So everything from their health provider office and clinic to infusion centers, the monoclonal antibody regional centers or MARCs are there, and pharmacies, skilled nursing facilities, and then broader health systems. But the main goal was not for anyone to go to the emergency room and say, hi, I'd like monoclonal antibodies, because everyone has such scarce resources and staffing. We wanted people to get the medication in the appropriate settings. So I mentioned we have a pretty big county. This map is about half of it. It's obviously the western half in San Diego County. And you can see in the photo that we have another site. This is an adult kind of gathering center in our Parks and Rec in one of our cities, San Diego City, that was donated to the cause as well. The green circles are currently open monoclonal antibody regional centers. The orange is a coming soon, and the two red ones are at areas that we had high demand and high need and had that available facility. And then at different times, we just throughout the year have not been able to maintain locations at different facilities. So if we go to the next slide, we wanted to make sure that both providers can refer and patients are aware of it by providing communications to health professionals. So we have and maintain a health professionals website, and the link is here for you all. We've done different YouTube videos, and on the right, you can see the start of our website and making sure people have quick access to information. The next slide shows the collaterals that we had available both to our health professionals on the right, so tips for talking to your patients about monoclonal antibodies, but also on the left, information in multiple languages for patients so they can kind of absorb what is a monoclonal antibody, what does it mean to be high risk, and so forth. And then finally, public communications. So we raised awareness through different media campaigns. We have on the right, the San Diego Union Tribune with monoclonal antibodies as the first words there. And then on the left, a fire chief who was very willing to talk about his experience getting monoclonal antibodies. And that was published and on video in multiple different ways. So the next slide here is just the flow of a COVID positive person with symptoms, either referring or being self-referred to the monoclonal antibody regional centers. One of the things we learned as a best practice is we have a single phone number for all of our centers. So for the public, it's a single phone number to remember, that 619-685-2500. And then behind the scenes, we can change the script. We can have the calls route to different centers as they come up, as their hours change and so forth, and people can select that. But there's really only one access, one phone number to remember. When that phone rings, either if people leave a message, right now we have about 1,000 messages per site a day. I'm sorry, not a day, a week. So people can't always answer the phone, but in most other times, the nurses will answer the phone directly, review the patient's questions, and be able to schedule them if they're medically appropriate right then and there. And that's when they start the data collection that I'll show you in the next slide. And then, of course, all the way on the right, people can receive monoclonal antibody treatment at that sites. All appointments are made via phone after screening, and all of the assessment and intake is done on the phone. So people show up in the parking lot, they call to let folks know that they are there, and then they're brought in and right away get their treatment in the hot zone. And the other thing besides the phone number that has been universal for all of our sites is at the bottom of this slide, you can see that treatment is available at no cost, regardless of health insurance or immigration status. So the next slide just shows you a couple screenshots of our data tracker. What we used is our EMS system has a patient care module, and that's from Image Tracker. So it's part of our LEMSIS, or what our EMS team reports into our state EMSA. And so we were able to take that patient tracker, which is usually used for disasters and things like earthquakes or hurricanes, and we were able to modify it to be able to have a data system from point of call to be able to take in the demographics, the language, and the vaccination status, as well as zip code, and all the way through the patient care record to side effects, and then treatment and whether it was completed or not, and finally to the 1-day and 7-day follow-up calls so we can see the outcome. So all of that was done from that system. The next slide, you can see some of our data outcomes. So this is able to put information into Power BI, and we can get all kinds of different charts, which is also how we were able to determine where new sites needed to be started according to the zip code from which people came in order to get the monoclonal antibodies. So finally, I'd just like to thank all of our partners. It certainly takes a village, and thank you very much. I have our email address here, which is our central email address that we use specifically just for questions about COVID treatment, so that we can monitor that inbox 24/7 or at least 7 days a week, and be able to support folks as well. Thank you very much.
Jennifer, thank you so much. You guys definitely have quite a village.
Yes.
I mean, that was such great insight into how you guys' process has been set up and whatnot. So definitely look forward to talking a little more in the Q&A section, but thank you so much. That was very insightful. So, and last but not least, PJ is up next.
So again, my name is PJ Miller. I'm the medical director of the Medical Oncology ICU at Atrium Health Wake Forest Baptist. And I was asked to talk about our inpatient experience, as well as the challenges of obtaining monoclonal antibodies for this population once they're already hospitalized. And if your experience so far has been a frustrating one in regards to following literature and reviewing the data, we are really far in the Wild West here when it comes to inpatient, because the data is remarkably scant, and the challenges have been quite prevalent, I'll say. I wanted to present at least the first 2 patients that I experienced trying to obtain this antibody for. And again, being in the medical oncology ICU, as we started seeing a lot of patients with COVID coming in, and they were overflowing into some of our other ICUs, we started trying to determine which ones would be good candidates for receiving this therapy. And the first 2 patients that I had, the first one was a 60-year-old man with mantle cell lymphoma. He was on rituximab. and he was receiving this as maintenance therapy. He had been fully vaccinated for COVID-19. He developed upper respiratory symptoms 21 days prior to the transfer into our ICU. And at the referring hospital before he was admitted to that ICU about 2 weeks after admission for worsening respiratory failure. So he did follow this trajectory that we do see in a lot of patients, unfortunately, where it started out relatively mild symptoms and then continued to progress, and ended up in their ICU. And when they met the everything that they could provide there, they looked for transferring to us into our medical oncology ICU. He had received standard dexamethasone treatment, but had not received remdesivir. And the logic for that was he was believed to be outside a window of treatment because his symptoms had started so long ago in the past. And although this is a reasonable or potential logical thought process for patients without cancer or that are not receiving immunosuppressive therapy, we tried to take a step back and say, well, this may actually be a good patient to receive therapy because they're not mounting an immune response. And how can I really evaluate if they're mounting an immune response? Just because somebody has leukocytes on their differential does not actually mean that they're immune replete. So we opted to check the cycle threshold in this patient for his SARS-CoV-2. And we determined that his cycle threshold was 16.7 and 19.3. So that means over 3 weeks into his infection, he was as infectious as if he was in the first several days of infection. The next patient that we had encountered was a 77-year-old man with multiple myeloma. He had an auto stem cell transplant several months earlier and was currently on lenalidomide. He had also been fully vaccinated for COVID-19, and he was diagnosed 5 days prior to admission. And his treatment course was with remdesivir, which was then stopped when he received tocilizumab, and he had been initiated on a dexamethasone course. So these are the first 2 patients that I had right around the time when information came out that you could potentially receive this as a compassionate use for patients. And we very quickly jumped on it for these, both of these patients. Now, this was my mindset of how this would happen. So I identified a patient that I thought would be appropriate. I contacted our pharmacy, who is a godsend for me, and I have all of their numbers pretty much on speed dial on my cell phone at this point. And they keep me in line, making sure that I am following all the rules. And then we would just order this, and the patient would administer we would administer the infusion. The patient would receive it. That was my very naive logical mindset. This is actually what it turned out to be. So somewhere along the line, we identified the patient, and literally you'll follow those arrows. Each one is a different step along the way, and I'll discuss that very briefly on the next slide. But there were so many more steps that went into infusing this medication from when I had identified the patient. And this, again, is when I'm on service. So part of the compassionate use program is the prescribing. The person who is obtaining it for compassionate use should be the one who is managing the patient. So I'm on service now managing how many other patients at the same time of doing hours of background work. Now, we got very efficient at it. We cut our time down probably by about 75%, but still we're talking days that it took for the first one. So this is the pathway that it took, and I'm not going to necessarily read through everything, but you can see every step along the way, the left column going top to bottom, and then the right column top to bottom. Identified the patient, sent out a general email to the company. I was actually amazed. I received a response back within minutes. That was actually the most efficient part of this entire thing. Responded to the questions, received the next steps email. Then I had to call the FDA, request an EIND. Then I had to request to use the stock supply. So we had this medication in stock, but I could not just go ahead and administer it to the patient. Discuss this with the MD or the PharmD at the FDA. And then there was a whole bunch of background work, finding my most updated CV, finding a copy of my medical license, making sure that they could be sent in the email over to them. providing all the information for our pharmacy. I don't know our pharmacy's address, so I had to find that. Request to use our stock supplies I'd mentioned. Emailing everything back to the pharmaceutical company that I had already emailed to the FDA, completing different forms, contacting pharmacy to keep them all in the loop. Then I had the shock that I had to set up an IRB before I could even administer this medication. Setting up an IRB when you need something right now is a challenge. Now, granted, my institution was fantastic and we got this up and going so remarkably fast. But it was still an additional step. And again, I'm rounding, I'm seeing patients and I'm being pulled away to try to answer all this stuff. And all this has to be done at this time by me. And also all of these forms are paper at this point. Now there are actually editable PDFs that you can just email right back. But before I had to print it out, put everything in, scan it, fax it, or put it back into the email. Not fax it, nobody really faxes much anymore, but get it back to my email and sending it back. Then I had to consent for this. This is compassionate use. So I had to develop an entire consent form, or actually find help, somebody who knew what they were doing in developing an entire consent form. And then recognizing, well, my patient's too sick to sign this consent form. So now I have to get the next of kin to sign the consent form, getting it set up so I can email it to them because they can't come to the hospital because their loved one has COVID-19, they can't visit. And they probably also are exposed to COVID-19 at the same time. So I don't want them to come visit and sign a consent form for me. And it always seems to be people that have the least computer literacy that I would be helping walk through this consent form. And then can coordinate with pharmacy regarding the timing and infusion. So as you can see, there were so many steps that actually went through into identifying the patient to infusing the medication. And then this leads now to a whole bunch of questions. So which patients do we want to do this for? Well, I think the data, again, is so scant, and we know that the variants are differing in how these medications, how these antibodies are effective against each of the variants. So I don't have a great chart to say, use this, use this, use this. Why? So many things go into it. Not only which variant, which antibody will work against which variant, but is your institution capable of all these steps for when you have to do this for your patients? Do you have the ability to have other people help you set this up? So one, you're providing good care to this patient with COVID-19, but that you're also not neglecting all of your other patients that you're managing at the same time. So in my mind, reviewing all the data and having had experience now, I forget how many patients we've done this for, but we're definitely somewhere between 15 to 25 probably patients that institutionally that we have done this for. And I've been involved, not necessarily in prescribing it for everyone, but then once I did it, being able to walk people through each step along the way. So which patients? Again, you want this as early as possible into their hospitalization. Why? Well, we know bad things happen to critically ill patients the longer that they are in an ICU, irregardless of their actual COVID-19 status. So if you develop DIC and you have a multi-system organ failure secondary to DIC, well, that has nothing to do with the virus. We want to get you early when the virus is replicating and when the virus is causing problems for your critical illness. So again, as early as possible, and if the patient is not responding to standard of care. The question of whether or not you would do this within 5 days if you don't produce antibodies is also a really interesting question. So this should be something, if you have the ability to evaluate or check for a cycle threshold in your patient to determine, are they still having very, very, very acute infection, then that would be a person who I would be more eager to treat than somebody whose cycle threshold is indicative of resolving or resolved infection. Patient would have to demonstrate or be highly suspected to not have mounted an immune antibody response. So if I was able to check that they had developed antibodies against COVID-19, then I probably would not be as eager to provide this therapy for a patient. But if I know that they didn't, or I'm highly suspected that they have not mounted an antibody response to their vaccine, then yes, I absolutely would want to be aggressive in treating this patient. And specifically, but not limited to, patients that are receiving anti-B cell therapies. So again, something like rituximab, and patients with multiple myeloma, they just seem to have a very, very, very depressed immune response to mounting immunity against COVID-19, especially in regards to their vaccines. And again, I would also encourage everyone, first, do no harm. So remember to do the basics first. Once word got out there that we were treating patients with these monoclonal antibodies inpatient, we were getting a lot of calls from regional hospitals and places far outside of our network trying to get people in. And when I would ask the very basic questions of, is your patient receiving remdesivir, yes, no, or tocilizumab, or are they on dexamethasone, oftentimes that thought process had taken a back seat to trying to get the person to where they can get antibody therapy. So I encourage you, please, please, please do the things first that are very good evidence-based critical care for these patients. Give them, if they are candidates for tocilizumab or they're candidates for dexamethasone, do those basic things first. And again, there's probably questions about, well, what now do we do about Omicron? Well, in an ideal world, I would know what variant my patient has. And I don't have that ability right now. So currently, we're just following our local health department in regards to what we're seeing with the variant. If we see 100% Omicron variant, then I probably will not be using the monoclonal antibodies, because currently sotrovimab is not approved, even compassionate use to be given. So I can't necessarily work that into the patient's care. But I'll be keeping all of this and my experience in the background, because right now Omicron it seems to be resistant to these. However, who knows what the next variant will bring? Or as Omicron hopefully burns out, maybe if patients continue to be infected, they'll be infected with variants that are susceptible to these medications. That's everything that I had on my slides. And like everyone else, I'm happy to answer whatever questions I can.
PJ, thank you very much for your insights into some of your experiences that sounded a little painful at times. We've actually have some good questions from the chat that I just kind of want to follow up on. And I think Masa, as well as you, for kind of mentioning, kind of the Omicron, because I think we've had quite a few questions kind of surrounding that. And there's a lot of uncertainty. Like you said, I know that it was mentioned that, in terms of at least studies, there's quite a few ongoing studies that, of various other proteins. So I guess we'll kind of see where those pan out. PJ, there was one question that was just directed to you about, with ICU burnout and how busy we are with providers and whatnot. Was it worth the effort?
Was it worth the effort? That's a great question. So both patients lived. These first two patients, I'm sorry, the ones in the PowerPoint, both of them survived. So they're both home about to celebrate holidays with their families. So to me, yes, it was worth it. Now, I think a lot of that comes with, we were not able to treat every patient that we wanted to. We actually had supply chain issues that depleted our supply much faster than we were hoping for. And we had to shift from compassionate use inpatient to only approving the medication for outpatient use, where there was better data. Didn't necessarily stop me and other people from trying, but yes, I would say it was worth it. And I really hope that the experience that I was able to relay will help you be more efficient. The first time it took over 48 hours from thought process to infusion. We actually got that down to less than 24 hours. And now it's probably closer to 12 hours. And some of that is just when staff is available.
Yeah, thank you for that insight. No, and I think you brought up a valid point as well, because also being at a tertiary care university as well, we get a lot of hospital transfer requests and whatnot. And I think, like you mentioned, just focusing on evidence-based practice first and foremost is critical, because we get a lot of these requests similar to you for, wanting for some of these monoclonals or some of these other things that they can't always provide, but we have to remember that there are things that they can provide in the meantime. But Jennifer, along those lines, some people did have some questions about supply chain issues, or what happens if availability starts to go down? I mean, there has to be contingency plans or thoughts? I mean, that gets into some really difficult questions.
Yeah, no, those are great questions. And so really what we start with is we start with the EUA. No one at any site gets anything, obviously, if they don't meet the EUA criteria. And when supply is scarce, as it has been for different monoclonal antibodies throughout this past year plus, and it is again now for sotrovimab, then we absolutely fall back to our MOAC system. And as the allocation is made from the feds to the state, and then the state to the local health jurisdictions, we have the public health preparedness response team has made a great electronic, as we were talking about, electronic form, and it goes through making sure that everyone is providing the monoclonal antibodies in an equitable way. And also we keep track of everyone's supply. So what's the supply on hand? How much are you giving per week? And what is your request? And then that team goes through and makes the allocations. So right now we do have a couple sites that are providing sotrovimab, and we do have more than 50% on what we anticipate of Omicron right now in San Diego. So the agencies that are able to either by lab to detect that, or have different algorithms to look at how to prioritize people who are at highest risk. That's what we're doing now. But it's been very fluid as different medications are in different supplies and different things work with different mutations.
Oh, that's actually, I'm sure you guys did have a process, so it's interesting to hear that. I don't know if Masa had anything to add, if you had any comments about kind of, as like you said, as Omicron kind of starts to come into play, and either more variants start to come up, and what, and all the, which monoclonals are going to have more reactivity to one versus the other. I don't know if you have any thoughts on where we might be heading in that realm.
Yeah, I think we're all kind of stuck with the limited supply of sotrovimab and trying to figure out how to utilize that and get it to the most high risk patients. And as more data comes out, whether, a combination of monoclonal antibodies may be effective in overcoming the inability to neutralize this virus. Also, kind of thinking about future variants, and whether they will either retain, these monoclonals will retain activity, or, continue to not be active. And then, of course, just vaccination, I think is ultimately going to be the most important, with being able to, especially as monoclonal antibodies at this point become more scarce and are not as effective.
Yeah, absolutely. I feel at this point, I think it's just, I think as PJ mentioned, kind of relying on some of our pharmacists. I feel like at this point, I need to have like a cheat sheet card on all of the ones that are out so far, and because every study kind of have their little intricacies, and trying to figure out how to make mandates based on those is a little challenging. One more comment before we kind of before we get our final comments. Once again, this is back to PJ about what about maybe patients not in the ICU, but there's an intermediate care that may not be, might fly under the radar or might be missed.
That's a great question. I would encourage everybody to make sure that you utilize the severity degrees that are based off of the CDC and the NIH. Just because you're in an ICU, you may not be critically ill. Just because you're on a general medical ward, you may be critically ill, and that has to do with the resources of your hospital. So you do not have to be critically ill in an ICU. If you are providing higher levels of support, and that's on a general medical ward, that patient is critically ill. So I'd encourage you to use that, the critically ill, the severe and moderate, et cetera, for disease severity. We are here at Atrium Health Baptist, we are trying to continue to bring our ICU out into the general ward when it is needed. And one of the things that we're doing that we notice with not only cancer patients, but other patients that are on varying degrees of immunosuppression at outlying hospitals that do not have the same resources that we have at main campus, we're trying to develop a medical oncology ICU without walls. So we are trying to make ourselves more available to consultation, even if that's just a phone call of, hey, I have this patient. What do you think? Is there anything I'm missing? Nope, you're doing a great job. Sometimes that reassurance. So we're trying to do that as well. So become good friends with your hospitalists, become good friends with the ICU doctors, and make sure that you don't limit yourself to just thinking that an ICU patient has to be in the ICU. There's a lot of really sick patients waiting in the ED for a bed.
Yeah, great point. I think we've all are experiencing that, especially in these last few years. So I want to thank you all for taking the time. And in the last minute or two, I would just want to, if you guys had any final quick comments or thoughts, I would love to hear them. We can start with Masa first.
Thank you. Yeah, I think just final comments. I do think that monoclonal antibodies have been, especially for our more immunocompromised and high risk patients, like a treatment option that has really helped prevent, I think, hospitalization and bad outcomes and death. And I do think as we are in a position where monoclonal antibodies are at least at this point in time with this variant, many of them are less effective or not effective. Looking at things, trying to assess some of the oral antivirals that are coming out, possibility of giving IV remdesivir that still has effectiveness as an outpatient, and some of the logistics for that, because it is a IV course for 3 days. And then some of the other oral non-antivirals like fluvoxamine or things like that might be available for patients trying to treat them earlier before they end up in the ICU, where it is harder to not only is it harder, but not yet proved and likely not effective as effective in the ICU.
Yeah, it's very important. The outpatient world is really it's funny how that's becoming the novel new research for critical care because it's pre. Jennifer, final thoughts?
So I think what worked with us is the 3S model of really making sure we had the stuff, staff, and structure in place. And because of that and the data, we were really able to ramp up and ramp down according to the different surges, and even get ahead of the game on that summer surge where we were starting to see an increase and everything was closing throughout the state for monoclonal antibodies. And we said, give us one more week. And the state listened. And in that week, numbers went up. So we were then able to staff more, get more stuff, and really be prepared for that surge. So I think that really is a model, not only for the monoclonal antibodies, but as we're talking about for the oral antivirals, or anything during this pandemic and other times where we've got something in scarce supply, and we're trying to make sure that it's available in an equitable way throughout our county. And we've got 18 different cities, just as many different Indian nations, and lots of different languages. So making sure that we can provide things in people's neighborhood is really important to us. And of course, keep them out of the emergency department so our EDs are available for people who need them. Thank you.
Absolutely. Great takeaways. Thank you. And PJ, last couple of thoughts?
I'd say my last couple of thoughts are, again, do no harm. Provide good critical care first for your patients. Make sure you do the things that we all know truly are evidence-based. And say thank you to your other physicians, providers, and nurses. Burnout has been dramatic this time around. And I thank everybody out there in the community and academic medical centers for all the hard work that everyone else is doing as well.
Yeah, you make absolutely amazing points. So, well, thank you three for joining us today and sharing your wealth of knowledge. Really, absolutely appreciate it. I hope everyone has a happy holidays. Thank you for everyone joining, and we hope to see you at the next CHEST webinar. Thank you all.
Thank you.
Thank you.